It's a pleasure today to be able to talk about an update on the PSMA-4 data. And this was presented at SNMMI up in Toronto just last week. What I might do to begin is to give a little context about PSMA-4 and how it fits into a larger scheme. I think many of you know that PSMA-617, lutetium-177, has been FDA approved for a couple of years now. And the basis for that approval was the VISION trial. The VISION trial was a prospective phase 3 study that had standard of care plus or minus to PSMA-617 lutetium. In order to be eligible for the trial, patients had to have failed and progressed on a prior ARPI, which would be the androgen receptor pathway inhibitor, abiraterone, enzalutamide, apalutamide type agents, and a taxane chemotherapy, either docetaxel, cabazitaxel, or both. Now, these patients had a pretty limited life expectancy. The control group, it was only about 12 months. And the PSMA-617 lutetium was able to prolong survival, improve a variety of endpoints, and that led to the FDA approval. But today, if you want to be able to get the PSMA-617 lutetium, you had to have had prior chemotherapy exposure. So pivoting back to PSMA-4, PSMA-4 was conducted in the metastatic castrate-resistant prostate cancer, having progressed on an ARPI, but they were all taxane-naive, so no chemotherapy required. The study involved randomization of 468 patients. The randomization occurred between the PSMA-617 lutetium, given at a dose of 7.4 gigabecquerels every 6 weeks for a total of 6 doses. The other arm was an ARPI change. So if you were on enzalutamide, you could go to abiraterone, or if you're on abiraterone, you go to enzalutamide, and that had to be pre-specified at the time of the randomization, or what you were going to be doing. The primary endpoint of the trial was rPFS, radiographic progression-free survival. And very importantly, for those individuals who met the rPFS endpoint, they could cross over, if they were on the control arm, to receive the PSMA-617 lutetium. And they did. So let's back up one more moment and talk about PSMA PET selection. As it turns out that PSMA PET is used to select the patients, very similar to what was done in the VISION trial. In the VISION trial, about 87% of the patients who were scanned were actually eligible. Here it was 92%. So the vast majority of patients actually met eligibility criteria, and that would include a positive PSMA PET metastatic lesion, uptake greater than liver, without an exclusionary lesion, which would be a liver metastasis with uptake less than liver, lytic bone lesions, uptake less than liver, lymph nodes greater than 2.5 centimeters, uptake less than liver. So it was a little bit of positive and negative selection, but 92% of the patients actually fulfilled the criteria. So what do we find? First of all, the rPFS was strikingly positive, and it's been analyzed a couple of times, but I'll simply say that the most recent analysis had a hazard ratio of about 0.43, meaning that the PSMA lutetium more than doubled the time to the rPFS. The actual median was 12.02 months for those receiving the PSMA lutetium, and it was 5.59 months if you received the ARPI change. So unequivocally positive. Now, the overall survival in the initial analysis had a hazard ratio of 1.16, slightly above 1. There's now been an updated presentation, which I presented in Toronto, of the hazard ratio for the intent to treat overall survival, and that was 0.98, just right about 1, but slightly less. In order to interpret the data, you have to realize that the vast majority of the patients eligible for crossover actually did crossover. So more than 75% of the patients who were eligible for crossover actually did crossover. So you really, in many ways, are beginning to look at PSMA-617 lutetium either before the RP switch or after the RP switch. So it's a little bit, so many people got the PSMA-617 lutetium that it probably diluted out the overall survival. There were other endpoints as well, things like the symptomatic skeletal events hazard ratio was about 0.34, very strong. Objective response rates as measured by RECIST, 51%, really strong, but I think it's 24%. It had a complete remission, which is good. Time to PSA progression was strong. PSA response rate 50% or greater was what was it? I think it's 57% of the PSMA lutetium patients had a decline of PSA of 50% or more. So again, that's strong. If you look at the trial, there was also health-related quality of life that was positive. It was really positive across the board, except for the OS, which I think is in part conflicted by the high rate of crossover. Adverse events were actually better. The grade 3-4 adverse events were better in the PSMA-617 lutetium arm, and there was also an improvement in the serious adverse events. Discontinuations in the PSMA lutetium were the same as hormones, about 5%, and actually dose reductions were more common in the hormonal treatment arm as opposed to the lutetium arm. So in summary, we have an RPFS benefit. We have an OS that is essentially the same, 0.98 in the intent to treat analysis. We have a variety of secondary endpoints and toxicity, all of which are looking good. The Novartis team has stated that they will submit to the FDA in the second half of 2024. I'll take them at their word. We won't change practice unless we get an FDA approval. We'll see what the FDA says. You know, they'll look into things very, very carefully, as they always do. And I'm very respectful of their opinion. They've got a big job, and I'd like to think I work with them, not against them, when it comes to making decisions about what's good for patients. So in summary, a nice trial in the taxane-naive space, and perhaps we'll get an FDA approval. We'll see. I think there are two elements here. Element number one is that, the PSMA lutetium is just a more active agent than a second-line hormone. If you wanted to criticize the trial, you'd say, why are you giving hormones to people who've already failed hormones? And you turn out with about 5.59 months, which is not so bad. But I will say that these patients were selected to not be chemotherapy candidates. If somebody was having very rapid progression, if somebody was having, liver mets, somebody was having progressive pain, then they would not have been a good candidate for the trial. But I think the PSMA-617 lutetium is just a more active agent. We saw that in the VISION trial. We know that it's active even despite one hormone, two hormones, one taxane, two taxanes. This is an active class of agent. Well, first of all, we need to see what the regulators are going to do, because it will not be generally available without the regulatory approvals. I would think that there'll be patients who will continue to get second-line hormones because they may have kind of a little piddling disease. It's moving slowly, and they don't necessarily need something like the PSMA lutetium. I think that there will be patients who get SBRT if they're oligometastatic or oligoprogressive. They're going to be patients who are going to be appropriate for PARP inhibitors if they have something like a BRCA2 mutation. There may be a few patients, not many, who will be appropriate for a PD-1 inhibitor, particularly if they have a mismatch repair or high TMB. And they're going to be candidates for chemotherapy. And if we look at sort of the totality of options, I think what we'll see is that the PSMA-617 lutetium is going to be a good choice for many people, but it won't be the only choice. There are going to be some patients for whom chemotherapy will be more appropriate, PARP inhibitors more appropriate, PD-1 inhibitors more appropriate, and even hormones more appropriate. So it'll take a clinician's judgment to really make those decisions.